All right, welcome to the Doctor Trainer. We're going to do a question. Let's begin. Ask yourself, every time you get a piece of information, how does this change my differential? Well, what are we working with right here? So the one-liner for this guy is a 72-year-old male who's presenting with right-sided heart failure symptoms. And the right-sided heart failure symptoms are lower extremity edema, and you can sometimes get liver issues with hepatomegaly. There is no lung finding, such as crackles, so there's no left-sided heart failure. So looking at our answer choices, how can we deduce this? Mitral corridor rupture, which that's a left-sided heart failure type of finding, and we don't see crackles. Thoracic aortic aneurysms are rarely symptomatic unless they're ruptured or extending into the aortic valve, so they can sometimes cause aortic regurg, but that's a diastolic murmur. We're dealing with a holosystolic murmur. So the only ones systolic in nature are B, D, and E. So how do we decide which one's which? So if you remember your posts, this is our sternum. So let's just say this is the sternum. On the patient's right side is the aortic post. Left upper sternal border is the pulmonic post. Left lower sternal border is the tricuspid post. And the left fifth intercostal space on the left is the mitral post. Okay, so again, go back to what it's asking. It's a 3 out of 6 holosystolic murmur at the left lower sternal border. If it was pulmonic valve stenosis, that would be left upper sternal border. So we can only rule that one out. So ventral septal defect is actually a really good one as far as a distractor for this one, because it can cause a holosystolic murmur in a very similar area as the tricuspid valve. Sometimes it's associated with a thrill, and it's much more of a harsh sounding murmur. But you need to know what's going on with this patient. This patient had a recent pacemaker placed in the last 6 months. Pacemakers are usually placed into the subclavian vein, and these wires guide through from the subclavian vein into the superior vena cava. Superior vena cava is this way. This is the right atrium, so sometimes the wire will be embedded into the intraatrial septum. And then there's a wire that goes through the tricuspid valve, and they embed it into the interventricular septum. So that wire is sometimes not allowing the valve close properly. And if that valve is not closing properly, then you get tricuspid regurg. So that's not a typical finding to get VSD on these patients. So the right answer is D.